It's really not an oncology board, so I guess a little change up there. We're just going to discuss 4 different cases, and it looks like Dr. Connor's case is first. So here you go.
Where's the thing?
Use that as well.
I can advance the slides on this. That's fancy. I'll do this. Oops, wrong way. Doing just what Dr. Howe did. So this is just a case of that you might see in the office. A 46-year-old P1 premenopausal woman presents for an annual well woman exam. She doesn't have any specific complaints, but on your review systems, she does say she has a sensation of pelvic pressure and some new onset urinary incontinence. In Dr. Kaeser's world, this would be prolapse. In my world, it is not. Past medical history, she's got some hypertension, hypothyroidism. Past surgical history is cesarean and a lap chole. Underwent menarche at age 12. History of infertility. She had 1 pregnancy conceived with IVF successfully. No abnormal PAPs. No significant family history. She is a smoker, and on physical exam, she has a small anteverted uterus and a palpable mass that appears mobile and non-tender. So my question is, and I don't know, I'd like to make this as interactive as possible. What's your next steps? Anybody? Shout it out. Ultrasound, yes. Anything else you're going to do? Are you going to get any tumor markers for starters? Not till you see the ultrasound? Well, of course, I started with labs. I wouldn't really in real life. I would have gotten an ultrasound. But these are her lab results. So she's got a CA-125 of 56. What does that mean to you in a 46-year-old woman? Not a lot. She's got an HE4 of 68. Maybe that's a little more meaningful, but I don't know how many of you routinely get HE4s. CEA is normal for a smoker, and CA-19-9 is 12. Some of these other tumor markers, does anybody routinely get these in the setting of a pelvic mass? Pregnancy test is a good idea. That's always the first answer. I don't know if I mentioned, but she didn't report any abnormal bleeding. That is one thing in this age group, and about 55 to 65, that I'd really consider a granulosa cell tumor if she also had abnormal bleeding. So she's got this complex adnexal mass on imaging, some mural nodularity, and several septations. You get a CT scan, and she's got this thing, but nothing else. No omental nodularity, no peritoneal carcinomatosis, no lymphadenopathy. What would most of you do in this situation? Yeah, so all of these pictures are from an endometrioid adenocarcinoma, and that was, several kind of clues in her history point to that. A long history of dysmenorrhea and infertility. Maybe she had a long history of endometriosis that would predispose her to an endometrioid ovarian cancer. And they are often diagnosed at stage 1, unlike our serous ovarian cancers. So you wouldn't see anything else on the imaging, but she would need an oncology referral.
Is this mic on? Can you guys hear me? I guess I would ask Dr. Connor, how would you take it out? You knew I was going to ask that, right?
So we would, if it could be approached laparoscopically without rupture, that would be our mode of choice. I think nationwide there is maybe still some debate about laparoscopic surgery for ovarian cancer. Dr. D and I differ a little bit on this. I think I'm the more old-fashioned one in this scenario. I don't necessarily believe in ovarian cancer debulking in a minimally invasive fashion, but I definitely believe in ovarian cancer staging minimally invasive, and this is a case that you could do that.
Yeah, and in full disclosure, I want you guys to know what I do or what we do with your patients. Today I'm pretty much putting a scope in almost every person I see, to start off with. And my habit is I often book the case with robotic surgery, don't drape the robot, which means that there's a good chance I'm going to open them. And actually think there's a lot of value to that today. I think Dr. Connor touched on it a little bit this morning with neoadjuvant chemotherapy. You know, there's a couple of possibilities we're going to find. Either I'm going to put a scope in and see gross disease, and similarly, like Dr. Connor, I don't believe that we should probably be debulking gross disease. So then the question becomes, can I debulk her? And if I can, then I'm going to make an incision and do a traditional ovarian cancer staging procedure. If I can't debulk her, then I'm going to take a biopsy of gross disease someplace, make a diagnosis without making a huge incision. If I can debulk her laparoscopically and I can remove the mass intact, possibly through the vagina, in a bag or some mechanism of getting the mass out, I will take the mass out, hopefully intact, send frozen section, and if it turns out to be a malignancy, then I would debulk her robotically. And I think I don't believe there's any randomized trials for that at all, but there's certainly enough retrospective data to say that we're hardly the only place doing that around the country. There's a lot of places even going so far as to do debulking procedures robotically. I'm not a fan of that. I do think you got to feel all that tissue and find those small pockets of disease, especially in the upper abdomen. But that's my habit.
I think we got a couple more slides. Just to give you an idea of the scope of the problem, you know, a woman has a 1.3% lifetime chance of developing ovarian cancer, but an up to 10% risk of undergoing surgery for suspected ovarian neoplasm. 60,000 women have an ovary removed for mass in the U.S. each year, and somewhere between 12 and 40% of women referred to a GYN oncologist for an ovarian mass will have a malignancy. It is important who sees these people. Ovarian cancer is the most lethal of our GYN cancers. There's no accepted screening test. Symptoms can be vague, but appropriate referrals do change lives. The NIH has had a consensus statement since 1994 saying that if there's a high risk of cancer, she should be referred to a GYN oncologist, which is not what people in Europe do, like we talked about earlier, but outcomes are better when these in advanced disease, we show an improved survival advantage when the surgery is performed by a GYN oncologist as opposed to a general surgeon or a benign gynecologist.
Any questions about any of those cases or any of that decision tree as we go down it, or Cleve? Yeah, so the question was, if we looked in with the scope and didn't see anything on the surface and no evidence of disease, at least grossly, in the abdominal cavity, would we attempt to do it laparoscopically? Yes, I do. Yeah, I think, for me anyway, the ideal scenario is if the patient has not had a hysterectomy and we could bring it out through the vagina, that's perfect. Generally, we can get 8-10 centimeter masses out through the vagina without rupturing them. I do put them in a bag, though.
And even some really big ones, just an industry plug. The Alexis bag retrieval system can go in through the vagina, and you can get a giant 20 centimeter mass pulled to the vagina and then decompress it.
In full disclosure, I do that a lot as well. I put a very large bag through the vagina and then get the edges of the bag out of the vagina, decompress the mass, and remove it vaginally. Any other? Mark?
This was a true case, right?
It was.
What was your index of suspicion of his death?
It was high that it could at least be a borderline tumor, so I was careful not to rupture it.
I can't help myself, sorry. Looking at that ultrasound, that would be an incredibly suspicious ultrasound for me. And then again, physical exam is a big thing. Obviously, if it's mobile, my threshold for thinking it's likely benign is higher. Fixed masses, of course, I'm very suspicious. Age of the patient is a big one, but that ultrasound is probably the most suspicious thing.
So in that case, you didn't really know it was going to be the answer to the actual.
Right, exactly.
It sounded like you blew it ahead.
No.
No. Despite some of our radiology colleagues in town, we can't get histology until they look at it on the microscope. Yes, sir.
I did not, except for general pre-op labs, and actually all of those labs came from the referring provider.
Yes.
So the most suspicious thing, I mean, the ultrasound was what made it the most suspicious that it could be.
I don't want to speak for Dr. Connor, but for me, that's what it would have been.
Yeah, absolutely.
They referred it to you, was the gynecologist that referred it to you?
It was.
Like they had some suspicion of it.
It was actually because that gynecologist had done an OVA1, and with the combination of the HE4 and the CA125, the OVA1 came back as an elevated risk, and that's why they referred it.
If those labs hadn't been on, would you run it?
I would have gotten a CA125. I don't routinely get HE4s, but you got to be careful with interpreting a CA125 in a 46-year-old, especially with a history of probable endometriosis. So I wouldn't have gotten real excited about that, and I didn't. I got much more excited about the ultrasound pictures than the CA125 of 56 or whatever.
And I personally don't do any of the HE4 or OVA1 only because I'm doing the surgery. I do think they're good tests, and I think when we're deciding, do I send that patient or do I keep that patient, I think those are great tests to do. But if I'm doing the surgery, I only want that preoperative CA125 in case I find a cancer, then I can know whether or not it may be a tumor marker later on. All right. Case number 2.
Okay, so mine's a little shorter here on this. So this is a 42-year-old with no significant medical history, was having an LAVH with a bilateral salpingectomy for AUB. And there was some pretty significant pelvic adhesive disease found secondary to her 3 C-sections that she'd had. So an intraoperative consult for general surgery was made for lysis of adhesions, which took about an hour. After that was done, the hysterectomy went pretty smoothly. And after the hysterectomy, the cysto showed no jet from the right ureter. So this is kind of, I think, the only slide I had. I was kind of really more putting this on here of like, well, what do you do next? What's everybody's kind of consensus on? Okay, difficult case. You got no jet on the right ureter. What do you do next? Pre-op imaging. I don't know. This was not my patient, but I don't think they did any. No, there was no pre-op imaging of the kidney or urinary. So she has no. That's a good question, but there was no medical history at all. So, yeah. Right. So Lasix was given, and then, again, I'll just say this was not my case, but I was part of it after kind of all this happened. Lasix was given, and I think they waited about 5 minutes after the Lasix, and still no jet. So, yeah, 5 minutes and still no jet, so they waited longer.
So just out of curiosity, how many people cysto? Just raise a hand. Just curious.
Yeah, another, I think, very important thing to do after pretty much any surgery, I feel like, is to do a cystoscopy. That's a good point, Dr. D. Thank you. Okay, they gave Lasix. It's been, I think, 10 minutes now, and they've waited even before they gave the Lasix, so I think we're in the 15-minute mark now. So what next? An intraoperative IVP. Okay, so before things like that were done, they took the patient out of Trendelenburg and put her in reverse Trendelenburg. They opened her fluids up wide. They administered, I think they did fluorescein first. Do you guys use fluorescein? Anybody? Yeah. I actually got to see indigo carmine again just like a couple of months ago for the very first time since I was a resident. It was fantastic. You say I have it at Erlanger? Oh. It was more than $100 a vial though at Cincinnati, so we still use fluorescein. But they gave fluorescein, still no jet. They gave indigo carmine, and still no jet. So I think they're around the 30-minute mark, and so urology was consulted. Would anybody do anything else before that, or I mean, take a lateral stitch out? Yeah, they had unfortunately they had closed the port sites and taken everything out and closed I think the residents were closing the patient up and almost done when they were doing the cysto. So yeah, that ended up happening. So they ended up putting the ports back in and looking and couldn't see anything. And I believe the harmonic scalpel was used during the hysterectomy. So, but there was nothing over on the side, no sutures or anything like that. So, any ideas on what would you do next? Pass a stent, right? So urology came and passed a wire first. The wire went effortlessly, and they said you're fine, and pulled the wire out, and the patient went to the floor. Sorry, please. No, they did not. Yeah, that's what I asked if we had done, and they did not do that. And no stent was passed. It was just the wire. It was taken back, and then the patient the next morning had some back pain, but nothing bad. She was discharged, and then later that night came back in throwing up and extreme back pain. And they did a CT scan. I don't have the images, but as you can imagine, there was some hydronephrosis and residual CT contrast in the right kidney. So this patient ended up getting taken back to the OR, and a retrograde pyelogram was done that showed a kink, but a wire could pass through the kink, but it wasn't enough to allow urine to go antegrade. So they ended up placing a retrograde double J, and she went home. So that's what happened there. I mean, so, you know, there's a lot of mistakes, I think, that happened within this case. I feel like just passing a wire is not enough for me. I don't know how everybody else feels about that, but that's not enough for me. I probably would have placed a stent, and if I'd seen urine coming out of the stent, maybe I'd be a little more happy, but you could easily place a stent right into the abdominal cavity if it had been transected. Really the right thing to do would to have a retrograde pyelogram done. So a stent would be placed just in the distal ureter, and omnipaque shot over a C-arm, and then you could see, is this extravasating into the abdominal cavity? Is the contrast going up into the kidney? And if so, you know, then we could just place a double J. If you see extravasating, obviously we've got a tear. Maybe you could just do a stent based on whatever the urologist thinks, or maybe they need a ureteroneocystotomy. I mean, it depends on how bad it looks. So, and like your good question or your comment, I think doing a laparoscopy at the time of that was even more ideal than just a retrograde by itself. So yeah, so that was kind of a big mess that happened. Thankfully, she's okay and is home without any problems. But yeah, we got called after she came back that night. So yeah. Any other questions or comments about that, or anybody done anything different? So that's the problem with this case, was that there were 0 sutures placed internally. You know, a lot of procedures that I do, like if I'm doing a uterus sacral suspension or sacrospinous or something, or sacrocolpopexy, I mean, if I don't see a jet, I'm going to go in and cut a stitch. I mean, that's easy, you know, like, okay. And I don't ever close anybody up until I know that it's working. You know, doing an IVP is pretty good. At retrograde pyelogram, just as, I mean, same thing pretty much. I mean, you're just going to shoot contrast retrograde instead of antegrade. And then you've already got the stent and the wire there, so that can help out. And if you need urologist help, it's already in the room, and you've already been going. So, right.
The only comment I'd make is, you know, with all the shortages of indigo and methylene blue, I've routinely started giving Peridium preoperatively, and that way I have some dye. And I do cysto everybody after the fact, and I wouldn't hesitate to put the laparoscopic equipment back in and visualize the ureter all the way to ensure that we didn't put the wire or stent into the abdominal cavity. So.
Yeah, and likely what happened with this lady was that it was a thermal injury, probably just close enough to the ureter where it caused it to kind of scar down but not be completely occluded. So that's probably what happened. And that's, that's awful when that does. So, all right, well, thanks.
I just kind of want to put another,
Okay.
a different method for an after hysterectomy cystoscopy. I actually don't use any cysto equipment. I just use the suction irrigator with sterile water. I put that, remove the Foley, put the suction irrigator directly into the urethra, and then use my 30-degree 5mm laparoscope to look for the jets. Just another option. Yeah. Oh, this is actually those.
Okay. Next slide. Do we have the ability to do it? There it is. Nope. Backwards. There we go. Okay. This is not a real patient. I just made her up. Sorry. But it's something we see a lot, though, or I've seen probably 2 or 3 times a year. So I think from some of the questions I got earlier, maybe Dr. Connor even already hit on this one. 71-year-old postmenopausal bleeding times 2 weeks. Typical patient history of diabetes, hypertension. She has an endometrial biopsy, reveals complex endometrial hyperplasia with atypia. And one of the questions this afternoon was, well, what would the majority of people do after that if they've done that far, I guess? Somebody had asked me if D&C is the next step, and I think that could be appropriate. I don't know how you guys feel about that. I think if you had complex endometrial hyperplasia and somebody was trying to decide, again, send her or not send her, D&C may be appropriate. I typically would just go right to hysterectomy in that scenario. Depending on which paper you read, anywhere between 20 to 40% of complex endometrial hyperplasia with atypia, the final hysterectomy specimen will reveal endometrial carcinoma. And on this patient, or typical habit would be robotic hysterectomy, BSO, and then do a gross inspection of the uterine cavity. If it looks like malignancy, my habit again is to do frozen section. And again, on this particular patient, and my habit again today is I've been injecting all these patients with ICG at the start of the procedure, and if we do find a malignancy, it makes it easier to do a sentinel node dissection. So as it turned out in this particular patient, had a moderately differentiated endometrial carcinoma with 60% invasion. So again, I think one operation would be ideal for these patients, where they possibly even were injected and had a potential opportunity to have that risk assessment done with sentinel nodes, versus potentially having 2 operations or just being treated with radiation and chemotherapy. For this particular patient, based on just the pathology that we have, there's a number of risk factors that we look at when we decide whether or not somebody's going to get adjuvant treatment. And typically it's age, grade of tumor, grade being 2 or 3, depth of invasion being greater than 50%. All those would be what we call intermediate high risk factors that would likely we'd recommend some additional radiation and chemotherapy. Cleve? Yeah. So the question is, would we do an MRI of the uterus? On occasion, I will. And the one indication that I have for MRI in this particular scenario is if somebody wants to preserve fertility. If somebody wants to preserve fertility, another option for treatment would be to treat with progesterone therapy. only if there's no evidence of invasive carcinoma into the myometrium. So in that scenario, DNC would be appropriate, number one. Number two, MRI would also be appropriate to determine whether or not they had myometrial invasion. If they have myometrial invasion, the likelihood of being able to rid her of that disease is zero, and the uterus needs to come out. But if there's no evidence of myometrial invasion, it may be appropriate to attempt to treat her with progesterone therapy.
As far as the issue of DNC goes, depending on which paper you read, DNC isn't necessarily more sensitive than an endometrial biopsy. So there's some evidence if you add hysteroscopy to that, you can increase your sensitivity. But I don't know that, especially with an EMB that's already positive, there's any role for a DNC unless you've got a medically inoperable patient that isn't going to be able to get a hysterectomy, and maybe you're going to place an IUD for medical management, or in some extreme circumstances, like she lives 2 hours away and you're deciding whether or not you have to refer her. Well, I think that changes things a little bit. That drastically reduces your risk, and personally, I'm fine with any benign gynecologist taking out that uterus.
So,
That's a good question. I don't think it's necessary.
would you do first off, if the original pathology on your office endometrial biopsy just revealed complex endometrial hyperplasia without atypia, risk of having an endometrial carcinoma in that scenario, I think is quoted between 5 and 10%. So I think the risk is low. I generally don't do DNCs in that scenario. I agree that the sensitivity of an office endometrial biopsy is upwards of 93 to 97%. So I don't do that additional procedure. And I think it'd be fine just to go to hysterectomy or to treat with progesterone. Yeah. Yeah, I don't have any definite statistics. I can only tell you anecdotal data. I do see a number of those that have even come back with higher grade abnormalities and even positive lymph nodes. And again, statistically, I would think it would be low, but I don't know what the number is.
But you just see weird things, and depending on where it arises, I've had one that just happened to arise at the fundus right next to the ostia and spread into the tube, and so she's upstaged, automatically. And surprisingly, you'll see somebody who had one episode of postmenopausal bleeding, had a grade 1 biopsy, you think it's going to be no big deal, and then she's got 80% myometrial invasion. I just think it's really hard to predict.
Any other questions? Nope. Yes? Yeah. Number one, I typically use Megace 80 milligrams twice a day. I have increased the dose of Megace for larger BMI, but I also judge that on symptoms. If the bleeding completely stops, I think 80 twice a day is adequate. If the bleeding doesn't stop, I've used higher doses, like 120 twice a day. And then typically I'd repeat the endometrial biopsy again in 4 months.
I use IUDs a lot and add Megace to them if I'm not getting control either of the bleeding or resolution of the hyperplasia on subsequent biopsies. I biopsy every 3 months, but that's mostly in patients that we're trying to preserve fertility. So it's kind of rare with these medically inoperable patients. sometimes I just go by their bleeding. You know, if I'm never going to operate on them, what's the biopsy going to change?
What's the advantage of Megace over
Over an IP.
I don't know if there's any difference between the two. Megace is just something I've been comfortable with. So I think you could use either one.
When I was in residency, our chairman told us that the, feel like we were feeding an acetate because it had a station attack. So I said the same question, is that something more potent?
Yeah, I don't have any data for any specific progesterones. I think they probably would all have similar effect. Just as a curiosity, just another, you know, let's say a 45-year-old with abnormal bleeding who's morbidly obese. You know, do you guys typically cycle those people and put them on chronic therapy? Does anybody in the room put them on chronic therapy in an attempt to decrease risk for endometrial carcinoma? That one, it was 45, but no. What about somebody in her 20s with PCOS? I'm asking, I don't see a lot of these patients. I only see them after they have cancer, so I'm curious.
What is what was this patient were on unopposed estrogen? Would this be a cause of this?
For sure, if this person was on, the question was unopposed estrogen, would that be a potential cause? For sure. In this age group, if she was on unopposed estrogen for any length of time, that would increase her risk for sure. And
Tamoxifen.
yeah, or tamoxifen, or, and this was the point I was also making, is that, or morbid obesity. You know, morbid obesity, in my opinion, is just unopposed estrogen, potentially. Okay, next case.
This is not one of my patients, but something kind of interesting. So we're going to do another annual exam. This is a 65-year-old female who presents for a routine annual. She denies any GYN symptoms, so no vaginal bleeding, no history of pelvic pain or pressure, or any other GYN complaints. She's had no significant past history, but on physical exam, she had a 6-centimeter rectovaginal mass. And I probably should have stopped the slide right there and asked if anyone would have gotten any imaging studies. Yes. What would you have started with? Yeah. So this provider did not start with an ultrasound. They started with a CT scan that showed a mass infiltrating the uterus and posterior bladder wall, rectum, and pararectal tissue. So because this patient was also 65, and because of the CT scan findings, they got a colonoscopy that showed some from a suspicious area, but they just read it as no evidence of malignancy. Pap smears have been normal. Thoughts after this? They did not. So would you do that by ultrasound or? Okay. So they actually got a pelvic MRI that showed 2 complex masses. You can see one in the vesicouterine pouch and then another in the rectouterine pouch. What would y'all do after this point? So it's me presenting, so you know it's not cancer. They actually did an office cystoscopy. And they showed a friable lesion on the trigone, but they didn't get a biopsy specimen because they thought that there would be a high risk of bleeding. Dr. Kaeser, would you have done an office cysto at this time? Would you have done an office cysto?
Yeah.
Yeah. Okay.
And then rectal, like exam, there's mass on the rectal.
So they didn't biopsy during the office cysto, right? But they ended up doing a laparoscopy and a cystoscopy, and you can see the findings here. It ended up being just endometriosis. And we normally don't think about that in a 65-year-old, but we have to remember that endometriosis can still be around. This patient was asymptomatic for pretty much all of her life, but it just happened to present in the postmenopausal period. In an asymptomatic person, you don't necessarily have to do complete resection. We all know what endometriosis is, but of something to note, malignant transformation of deep infiltrating endometriosis is low. So it is about 5%, especially in women with asymptomatic lesions. Sir?
Was she on any hormone therapy?
She was not.
Was she obese?
I don't remember.
Do you think this was long-standing, been there for years?
That's likely the cause. Just undiagnosed in the past. As we all know, endometriosis can only really be diagnosed by laparoscopy. She had never had any surgeries before to see inside her pelvis or abdomen, so this was just there. What's that? I would have biopsied if that were mine. Not necessarily if she was asymptomatic. Like I said, because of the low transformation rate and because she is asymptomatic, we could have just watched it, followed her with annual exams. One option for medical treatment if she was asymptomatic and didn't want surgery would be aromatase inhibitors. That is a good point, and that's something that I would definitely talk to the patient about, because even though that is 5%, it is still 5%. That's a really good point. I could have offered the laparoscopy as well, and see if she wanted me to do a resection. Sir? Well, again, this was not my patient, but they actually just followed her. Yeah.
I got a comment on that. I agree with Dr. Hobgood. I couldn't have let that CT or MRI go. I would have resected her. So that probably the wrong thing, I guess. So if she truly only had endometriosis, but it certainly looks a little suspicious. And I've not seen endometriosis in the bladder, but Dr. Kaeser says he's seen it once before. Interestingly, we're looking at a quantity of patients that are postmenopausal that we've had endometriosis biopsies on, and it's currently one of the projects we're looking at. But how often would you say we see endometriosis in the postmenopausal population?
Not very.
Yeah.
Not very at all.
I recently had a patient, just interesting. She had a remote history of, I'm going to lose that thing. She had a remote history of a hysterectomy and BSO for endometriosis. And this was, 20 plus years ago. She came to a general surgeon's attention initially because she had a palpable mass in the groin that he thought was a hernia. Turned out to be a mass. He biopsied it, and it was cancer. And she was sent to me, resected it completely, nothing else on imaging, nothing intraperitoneal. She just had an endometriosis implant in the groin that had transformed and turned into cancer. So, the rate's low, but it happens, and I think that's one reason why if you're going to replace hormones in these patients after a BSO for endometriosis, make sure you're giving them a progesterone too.
I don't, you know, I admit I'm biased because we seem to only see cancer. So, you know, I have seen where endometriosis transforms a number of times, but again, the population that I see is so biased because they're all from all of you coming to just a couple of us. But, you know, we do see it. So if I saw a mass like that, just based on, I would want to take it out. Yeah, so the question was, would the morbidity be worth it? In retrospect, I would have been wrong. So, yeah, but I don't know how we would have found it. I guess biopsying the bladder would be the easiest thing. Would we all feel comfortable biopsying the bladder? I have one spot of endometriosis with those two other masses. I'm kind of thinking like Dr. Hopgood was.
Yeah, I'd probably feel more comfortable with multiple biopsies, but you're right, that's a morbid procedure. I mean, resecting part of her bladder, resecting her rectovaginal septum, you're going to leave her with no sexual function. That's extremely morbid for endometriosis.
Yeah. Yes, sir. Yeah. So, the most common cell type that we see with endometriosis is clear cell carcinoma. Second most type, I believe, is endometrioid adenocarcinoma.